Well, our keynote speaker is Dr. Corey Waller, MD, MS, Fellow of the American College of Emergency Physicians, Distinguished Fellow, American Society of Addiction Medicine. Dr. Corey Waller is a board-certified and actively practicing addiction and emergency medicine specialist with experience working at the local, state, and national levels. Dr. Waller is the managing director of the Institute on Addiction, a nationally recognized expert in substance use disorders. He is the editor-in-chief of the ACM Criteria. We will have a question and answer session at the end of his presentation. So if you would direct message me any questions so I can read those out to him at the end, that would be wonderful. We'll get to as many as we possibly can. But presenting on what neuroscience tells us about building the addiction treatment ecosystem, please welcome Dr. Corey Waller.
Afternoon, everyone, or I guess still morning for you guys. So I plan to say something so that you're not having to give up on anyone, as the song would say. So the goal would be to really understand by the end of this, not just the basic aspects of addiction, and I hope that you leave this with a better understanding of really what the neuroscience does show us. Because if you recognize that behavior is predictable, behavior is something that we use to define this disease, and you understand why those behaviors occur, it sure makes it easier to start to understand why we can predict how to build a system and the best ways to do that. So, the goal would be at the end for you to be able to point to not only, oh, we need something like medication-assisted treatment, but it's because the nucleus accumbens isn't producing enough dopamine at the level that it needs to. So therefore, the lateral bed nuclei of the amygdala is having an increased fear response and a low serotonin response, which goes to the frontal lobe, which tells me that my medial prefrontal cortex is unable to make the decision that I want. You're not going to have to say that, but I think at the end, the goal would be to get you to recognize is that we know this, like we're not guessing anymore. And we still have some little pieces to figure out over time, but ultimately our ability to recognize cause and effect in addiction is pretty good right now. And so we're going to dig into that and then really help to try to understand what the systems are. So when looking at the stories like Val's story that we just heard and the story that you'll hear after mine, I think what we recognize and in the questions that came up and the answers that came is that everybody has their own journey, to recovery. And that's great. But that requires a system. It requires not that you're a hammer, so therefore everything's a nail. It means that we need to have an understanding that if you're going to have a unique path, that we need to have the ability to give you a unique path instead of just shoving you in a single pathway over and over again, and then keep telling you that somehow you're not ready to get better. I've treated thousands of patients in a number of different settings. I've worked at every level of care in addiction medicine at this point. And one thing I have recognized is that as we develop these systems and as we build it out to the appropriate level, this is very much a team sport. This is not I'm going to open up an office and I'm a doctor, so I'm going to save the world. This is I'm going to do my part. But it requires the ability for, all of us to really understand how to work together. And working together is different than working in parallel. And so having a common understanding of how we can best build these systems and how we can best interact with these systems is going to, I think, really drive us to have that answer to that question. And so as we go through this, think about that. What is your role? Because everybody has one. I can't do what a peer does. I can't do what an LCSW does. I can't do what a case manager does. I can do what I do. And my goal is to make sure that supports the work that others do and that it overlaps enough so that the patient doesn't feel like they're in separate worlds. Even the term patient is particular to a physician more so than other people who might say client. or those who might say peer, or those who might say person, and how they do it. And that particular definition is a specific one to me. And so even those things become really important. So as we go through, I wanted you, to recognize in an hour and a half, we can't write the entire book on this, but I'm going to try to pare it down so that we understand the basic neuroscience underpinnings of addiction in general, and not necessarily every little piece of every addiction for every person, but the basic neuroscience that is a part of all aspects of addiction, whether it be gambling, whether it be cocaine use disorder, whether it be opioid use disorder, alcohol use disorder. All of those have a final common pathway. And so we're going to dig into that. But please feel free to ask hard questions. I enjoy those questions. I prefer hard questions because we've answered the easy ones at this point. And I think that if you have a frustration or you see gaps or barriers in the systems that you're around, join the club. I poke at this all day. My entire world is about building a better system, both from the editor-in-chief standpoint for the ACM criteria, but also in what I do for a living. So I'm happy to dig into whatever depth of this that we want to learn. Just for understanding, I don't have any disclosures. I've never gotten money from pharma or device or anything like that. In fact, I'm quite sure that I'm never going to get hired by pharma, since I'm one of the chief science witnesses suing them in the opioid suit. So I'm pretty sure I'm not going to have that parachute sitting around anywhere. And we have some basic objectives here. And one of that will be the neuroscience of addiction, and also why it matters, not just that it exists. And then really apply that to what I've kind of coined as the 4 C's that we wrote a National Academy of Medicine paper about. And it really does pertain to you guys. So this is a simplified version of the parts of the brain that are responsible for a combination of addiction, trauma, pain, depression, anxiety, because all of those things live together, right? Nobody just has addiction. I've treated a lot of patients, and I rarely have someone who has an opioid use disorder. They're like, but otherwise I'm good. I don't have any depression. I don't have any anxiety. Never had trauma. No, never had an ACEs score of 1 million. This is just the common reality. And so as we start to approach the narrow conversation of the neuroscience of addiction, it's important that we recognize that it doesn't live by itself, that it's got its own baggage, and that baggage is sometimes really complex to work with. And if the more that we understand, the more that we can support those that we're helping along in treatment, to really have a good view of what their next step is, to recognize what they can set up as their future goal and have it be pragmatic, so that they don't feel like they failed, so that they feel like, man, I didn't feel like I went far, but that little bit that I went is big when it really means something. So we're going to focus on really these couple of areas around addiction. And each of these has a name on, the nucleus accumbens, the ventral tegmental area, the locus coeruleus, raphe magnus, reticular formation, periaqueductal gray, hypothalamus, amygdala, orbital frontal cortex, lateral habenula, medial prefrontal cortex, and thalamus. So again, you will not get your next paycheck until you pass the test at the end of this. I've been assured by admin, so take notes, and we'll all be good. So let's start with the basic concept of, we need 3 things to survive. You need food, you need water, you need dopamine, right? So I'll have my friends who are smart alecky science people who are like, we also need oxygen. And I'm like, well, of course we need oxygen, and we need skin as well to survive. But let's focus on kind of the food, water, and dopamine reward piece that we really want to try to understand and learn. And as we lean into that, we should understand that, having the ability to release a chemical dopamine is really the ability to have motivation. And so if you hear me say the word motivation, I want you to recognize that as me saying dopamine. And if I say dopamine, it means motivation. One can't happen without the other. And dopamine in that central reward axis is responsible for us finding a partner, and feeling the initial components of love. It's the part that creates, along with oxytocin, a mother-baby bond. It's the thing that if we do something good at work and we get patted on the back and said, until somebody told us good job, that makes us want to show up and do a better job. It's the chemical in the brain that drives us to go and do the next best thing. And it's important because without it, we don't survive. Without motivation, you don't get out of bed. Without motivation, you don't wake up in the morning and show up to work. And it's so important that it's been pretty well studied. And we have a solid understanding of not only the chemical dopamine, but what role it plays in this area of the brain called the reward system. You'll hear terms like limbic system. I'll talk about the nucleus accumbens in the ventral tegmental area, because if a person feels broken inside because of addiction, we should be able to explain to them why it feels that way. Just like if somebody's arm feels broken and they have a fracture in their humerus, they would be told what bone was broken. So we need to kind of start to understand these parts of the brain so we can help people to understand it's not just that they're, quote, a bad person. That they're not making bad decisions, that these are behavioral patterns that are really predictable, and why we can, call this a specific disease entity. So if we look at dopamine on a regular day, right, the amount that gets us out of bed in the morning, and got you your first cup of coffee, maybe the second, third, or fourth cup of coffee, depending on the amount of motivation required, the caffeine enhancement to that dopamine. It's about, let's say, 50 nanograms per deciliter. And this is a general, kind of an average amount. Obviously, nothing in the body happens at even numbers, but let's just call it 50 nanograms per deciliter. And that's what it takes us to get up and go do this. The bad day, kind of your worst day ever, the day you wake up in the morning, you don't want to go to work. You're just not gonna, you don't want to do anything. You call in and you fake vomit on the phone so you don't have to go in, and you do whatever you do that day, right? It's the day you don't get out of your pajamas, you lay on the couch, you go for a walk, you just keep sleeping. If you're me, you'll go in the basement and play video games. I still haven't gotten rid of that after my early life. So that is the escape. But whatever your bad day is, that's what you do. You do that. What about your best day? What about when it's great, when everything's perfect, when you've won the lottery, you own an island, and you have 2% body fat all at the same time, like instantaneously. And so that being the best day ever is about 100 nanograms per deciliter. Right. So we're supposed to live within this. Your favorite food, when we look at functional MRI studies, is around 94 nanograms per deciliter. So pretty close to best day, like your favorite food. And sex is about 92. Bummer on that one. But, maybe that research needs to be reevaluated. But that's what it shows. And so with that, we should really understand that this is where we're supposed to live. We're supposed to have bad days. We're supposed to have good days. We're supposed to have great days. And those are supposed to naturally occur. Those are supposed to be, I saw my kid score a goal in soccer and I bumped my dopamine and I really felt that. I should have the capacity to get an award for doing something positive and feeling that dopamine, or just doing something nice for somebody else and really feeling that and getting that bump in dopamine. I would say in the field of addiction, you better have a lot of self-reward capability. Because the pay in addiction is very different than the pay in a lot of other fields. So you need to feel very rewarded in this space naturally in order to do it on a regular basis. And we have people that live at different levels of this, right? So we have people that are naturally a little higher on that scale, that they wake up every Monday morning and they're like, yes, it is freaking Monday. I can't wait for the week. It's going to be awesome. That's a little annoying for most of us, but then we have the other side, which are the Eeyores of the group, right? They're like, well, it's Friday, 2 more days, we got Monday again. There's like no way to make them happy. But either way, we live there. So when we disturb this system, we kind of really disturb our homeostasis, our ability to live in the world that we live in. And when that happens, we create these maladaptive responses in the brain. And so when we say these, quote, neurobiological changes that occur, and, the longer somebody's on a drug, the deeper that these, quote, changes occur, it occurs because we're starting to force the brain to do things it doesn't want to. So if I give somebody methamphetamine instead of that 100 nanograms per deciliter that we talked about at Best Day Ever, we're looking at a release of, about 1,100 nanograms per deciliter. We're looking in the 900s for heroin and the 700s for marijuana and alcohol and nicotine. So, and even if you're looking at gambling and that. So when we evaluate the brain on functional MRI to see kind of what it looks like as far as release of that, we have this massively disproportionate release. And we've known this for a long time. I mean, the first studies on this were in the 80s, and they've just consistently shown the same thing. And if this is the case, the brain does not like to be told what to do, right? And if that 1,100 nanograms per deciliter, it's never going to produce that again, ever. And so the next time I use methamphetamine, it may go to 1,000, but it's not going to 1,100. And my patients would describe that as chasing the dragon. They would say, I can never feel that same high that I did the first time. And the answer is, you're right. Neurobiologically, the body had to protect itself. And so it tried early to turn that down a little bit. And so for that same stimulus, you're not going to get that same reward ever again. And if you continue to use, then you're going to decrease that dopamine to 900, to 700, to 500, to 300, to 200, to 100. And for the case of opioids, really specifically, if you continue to use heroin or oral opioids or whatever form you take it in, you may get down to the point where even when you use that opioid, let's say you inject a 0.5 gram of heroin, you may still only get to 50. That may be like what your brain is required to even maintain feeling normal. And so if you've heard someone say, well, if I don't use, I don't feel normal, I can't feel anything, that's a neurobiological truth. So this isn't them trying to come up with a construct and an explanation. This is just the neurobiological truth for what's happening. And as this, cranks up over time and we just beat up all of these areas, because think about that. When you take a drug, you don't take it in one part of your brain. It works everywhere else that it binds. So not only is it going to really fundamentally start to wreck your reward system and have your body respond by making less and less dopamine over time, it's going to actually start to atrophy the nerves that make dopamine. So it's going to, when it says, well, I can't release any less, so I'm just going to decrease the size of the nerves. And then if you continue even after that, we have good data to show that with this and methamphetamine, that you actually will kill nerves. So the brain will go through what we call apoptosis, which is a programmed cell death. It'll say, I just don't need it ever again. And it'll turn it off and start to kill the neurons responsible for sending the signal for motivation from the ventral tegmental area to the nucleus accumbens. And when that happens, we end up with a system that is this spindly little busted system that doesn't have the ability to send signals for pain, because periaqueductal grays where our endorphins come from, and opioids affect that. So we spit out these little bit of endorphins to handle our day-to-day pain. So you're probably going to have a different pain experience than most people. You're going to have this decrease in the signaling for dopamine between these two areas here. And dopamine, when it's released, will go down to the amygdala, which is kind of the emotional part of the brain. And in that part of the brain is the area for fear. And it's what we call the lateral bed nuclei. So this is a specific area. And dopamine, the higher the dopamine, the less the fear, the more complacency someone will have. So think about when you're like motivated, you're not really anxious about it. You're ready to go. You're ready to go and do this thing. And if you have high dopamine, you're not fearful of that thing. You shut down that part of the amygdala. But with less dopamine goes a higher fear. That higher fear response becomes really important, because when you have fear, you start to have disproportionate behaviors associated with that fear, and that disproportionate response to that fear could be rapid relapse. It could be an easy internal conversation with why it's important for you to continue use, or to sell your car to go buy drugs, or to take a little bit of money from grandmother, or to do these things that to someone not in this cycle of high fear, low dopamine, doesn't seem logical, but to this person who's in that moment feels very logical. Now, there are other parts of the brain that are a part of this as well, that are part of the habituation cycle, the thing that is the "this is what I do" cycle. And so this phenomenon, and it's areas like the orbital frontal cortex and lateral habenula. But the fundamental change in the brain that requires motivation to be helpful is what we want to focus on now. Because one of the things for those of us in treatment that feel very frustrated by is this idea of readiness readiness for change, right? Are they ready to change? If they're not ready, they're not going to do it. Well, if you never produce dopamine, you're just never going to be ready. And so motivation to get better requires a chemical that their brain is not producing. And so sometimes we can't wait because the next dose might kill them. And so this is where we start to get into relative risks and responsibilities of providers in this, and the urgency with which we really have to lean in to treatment. So as we start to look at, what happens after this, that if we start to look at what's going on in the brain with a decrease in motivation, we find people that in this low dopamine state, they have a high fear state. That high fear state starts to get to a little bit of panic and almost survival mode in a sense. And when that happens, we start to see these really predictable behaviors occur. So when you get this lack of dopamine, you get craving, and that craving is steeped in fear. It's not like, hey, I'd like a steak tonight. It is, if I don't get this, I'm going to die. I'm not going to make it. And you get into this panic state, which gets into survival mode. And then we see these primal actions. And those primal actions, like I said, could be really small at the beginning. They could be, I'm going to be a little bit late to work because I got to go pick something up before I go to work. It could be, I'm going to ask for my check a little early because I don't have enough money to go buy something I need to be able to work. And you can justify internally why that could happen. It is about, figuring out, well, maybe if I just borrow a little money from a friend, it's not I'm stealing from a friend. I'm going to borrow some money from a friend. And the intention is there to pay it back. There's not this nefarious human being that just appeared out of nowhere. It's these behaviors that seem internally justifiable in a sense of panic and in a survival mode. Just like we see survival mode in areas, of famine. It makes a lot of sense logically to the person in survival mode who doesn't have food to maybe steal some food from a neighbor. And they can justify, well, they have plenty, they don't need this, I can do this. And that makes a lot of sense. And quite honestly, to the outsider, it makes a lot of sense. Because I get that, you need to survive. But we've seen, countries go to war over famine, go to war over lack of food. So, there's really very little limit to what we will do in order to obtain food and water to be able to survive. But these primal actions are so consistent and so predictable in addiction that they constitute the actual disease. And so if we look here, this is how we define the disease, right? We define the disease based on behaviors, not the presence or absence of a drug. We talk about the impaired control, the social impairment that's an aftermath of continued use and impaired control. And then when things the wheels really start to fall off, the risky use. Yeah, I don't know if that's a clean needle, but I'm going to use it because I need this. I don't know who made these drugs or why they made them, but I'm going to use them. And, so you start to walk down, these pathways and they become really, really predictable. And so one of the things I think is really important for everybody to take away from this is this phraseology. We don't define addiction based on the presence or absence of a drug, but based on the behaviors associated with obtaining or using a drug. And this gets to this fundamental concept of, well, I'm just replacing one drug for another for MAT or other things. Because if I started somebody on a medication for addiction, buprenorphine, methadone, in those settings, and these behaviors all stabilize, they're in remission. They're no longer in active addiction. And so they meet for an opioid use disorder in remission on opioid replacement therapy. And so therefore, we haven't replaced one drug for another. What we've done is fully stabilize behavior with a therapeutic dose of a drug that's meant to stabilize that dopamine axis, which is exactly what we're doing with medications like buprenorphine and methadone. What we're doing is we've identified two very safe medications that when given at the therapeutic dose, stabilize dopamine in the normal range. They don't bump it up to that 800, 900 level. They just keep them at 50 so they can make a basic decision. Because I will tell you that someone whose dopamine level has gone down, to 30, 20, 10, if I try to sit down and, give them therapy or give them psychoeducation, what they hear is rah, 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 rah. They don't hear my cognitive behavioral therapeutic, pathway. They're not hearing the brilliance we're espousing to them in that moment that we feel very emboldened by, and then we wonder why when they come back for their follow-up appointment a week later, they don't remember a thing we said and they haven't practiced any of those skills. And, and we internalize that and they're like, well, they just don't want to get better. It's not that. It's just that you can't actually do those things if you're not producing dopamine. And so for the subset of the population that is not able to naturally produce dopamine appropriately, we have to be able to stabilize it. Otherwise, everything else we do will most likely fail. And that's the piece. This is a piece of the puzzle for opioids that is without question the easiest thing to stabilize. And in fact, I want to make sure as we start to get into other aspects of how dense this craving can be, that we remember that opioid use disorder is the easiest addiction to treat by far as compared to the other addictions. And that's even with trauma, even with a co-occurring disorder, even with homelessness. It's still easier to treat because we have a solid medication that stabilizes dopamine in much the same way that it was messed up at the beginning. So, but I think to really get to this behavioral piece, we need to understand this next piece. So what is craving, right? To really understand the behaviors and the extremes that these behaviors can go to sometimes, we need to understand the neurobiology of craving and what that means. So what is craving? So for us, it's this a direct or indirect force pulling someone toward a substance or a behavior. If we go back to high school, which is a scary thought, right? But if we go back to high school and we think about the person we just broke up with, and why do I still have a craving to call them at 4 o'clock in the morning? Why do I still have to do this? Because the body is drawn to that because it knows that it got dopamine at some point from that person. It knows that it got a positive response. And that's a normal human interaction. You don't just turn that off. And interestingly, it can be triggered years later. So you can have broken up with somebody, be married with kids and have all of that. And I'll have friends be like, I just got this weird email from my ex-girlfriend and I had this weird thought, and I'm like, don't go down that path. But it can flip that like a switch, right? And so these are the things that we identify that happen normally. So what happens if we have a disproportionate input outside of that kind of normal pathway? Well, if we look at this, and when we looked at this for science, we looked at the portion of this that talked about dehydration. So they looked at people who had no water for 2 to 3 days. So that's a long time for no water. And they didn't give them IV fluids. So they had moderate, dehydration. So when you stood up, your heart rate went up, your blood pressure went down. And they put them into a functional MRI, which looks at your brain in real time and sees what parts are activating. And they would play water sounds in the background, show them pictures of water, sprinkle water on their feet, have them get a moist rag and spit it out and then look at their brain. And what they found in that population was that craving in that population was about the relative size of a baseball, not the actual size, but the relative size of a baseball. And then we did these same things. When I say we, the collective we, not me personally, but the science community, we looked at this for starvation. So they looked at people who had no food for 3 to 5 days. And within that cohort, they put them in the tube and they would waft in the smell of their food, that they liked. They would show them pictures of their favorite meals. They even had them like chew it and spit it back out and then look at their functional MRI for craving, which is the anterior medial prefrontal cortex and a few other locations that'll light up for that. We call that cue associated craving. And it was significant. It wasn't the size of a baseball. It was the relative size of a basketball. And again, we know what people will do in states of starvation and active dehydration. You get to that point and you will beat somebody up for a slice of bread. You know, you will do what you have to survive. And actually we'll justify that from a humanity standpoint. We do that on a pretty regular basis. Like if I was there, I'd do the same thing. And I think we can understand that. Well, what about when we have this massively disproportionate craving? And so people with opioid use disorder and alcohol use disorder were looked at, and they had been off of their substance of choice, not on medication assisted treatment, so just abstinent. And they were looked at 30 days, 60 days, 90 days, 180, 6 months, and then 12 months, 18 months, and 2 years over time. I think one of the important concepts to think about at first was we saw a consistent increase in craving over the whole first year. It didn't plateau in 30 days. It didn't plateau at 2 months. It consistently went up all the way out to 1 year. And Dr. Yasmin Hurd's work in New York has been really instrumental in helping us understand this. And it's a bummer because even at 1 year, you're now at kind of your peak of craving in this population. And we didn't start to see any changes of improvement at all until about 18 months to 2 years at the earliest. And I think this starts to get at the question about medication, is that people don't even start to even begin to improve for up to 2 years. So we wouldn't even want to think about, you know, taking them off of medication prior to that, just because of all the benefits. And we can talk about that as well. But so when we looked at this for those, and we looked at all of that, at 1 year, the relative size of the craving in this population was not the relative size of a baseball or a basketball. It was the relative size of a baseball field. And so when we start to look at the disproportionate behaviors that we see in people who are in this, you know, really hyper-focused survival mode, it makes a lot more sense for why those behaviors would seem so irrational to us, but so completely rational to them. And so when we're thinking about why in the world would you do A, B, or C, when somebody has not stabilized their dopamine, they are not able to motivate, they are in full craving mode, I think we can explain a lot of those behaviors just based on this one piece, not to mention the other habituation behaviors and the neuroscience of trauma. You start layering all that on, and these behaviors become really just predictable. And you should just understand that the worse the behavior, the more severe the disease. You know, so the more outrageous the behavior, the more dangerous the behavior, the more consistent that those maladaptive behaviors are. It's the equivalent of having somebody with a blood sugar of 700. And so we would at that point surround that person with all the care that they needed to make sure that they got everything that we could to get that blood sugar down. And then over time, so let's say we get that blood sugar down. I heard you guys talking about diabetes, and it sounds like earlier today somebody had equated diabetes to addiction, which I agree with the analogy in this setting, especially type 2 diabetes, because people will be like, well, people don't ask for diabetes. I don't know about that. Type 2 diabetes, there's a lot of Krispy Kreme sometimes in that pathway. And what we identify for people with type 2 diabetes is that if you changed your diet, if you lost a lot of weight and you exercise consistently, the clear majority of people with type 2 diabetes wouldn't require any medication. But if they don't do those things, we still give them medication. We still treat that disease. We still treat it because we know that it decreases the total cost of care. It improves their function. It decreases the chance of hospitalization. It decreases the rate at which they die. And we do that because it's morally and ethically appropriate. And because, you know, there's this ethical principle in medicine called autonomy. People are allowed to make their own decisions. You know, we can't take on these draconian parental approaches to this. You know, I think we've realized over the last 2 or 3 years that people were really allowed in the United States of America to make stupid decisions all the time. And that's reality. We get to make those decisions. And so it's no different within this disease. The best that we can do is explain to people why it is important to utilize the treatment modalities that we have. For opioids, The treatment modalities that help with motivation are methadone and buprenorphine. And the reason I haven't talked about naltrexone yet is because it's a good med, but it has a space, but it doesn't really stabilize dopamine that we can identify for those people who lack motivation. And so if you lack motivation, and you can't get out of bed and you can't, and all you're doing is craving and craving and craving, and you need to go use something and you want to go use something, then you need something to stabilize dopamine, and buprenorphine and methadone will do that. And when I say buprenorphine, that's Suboxone, Zubzol, Bunavail, the 3 medications you can take orally. There's now an injectable that lasts for a month, and then there are some other injectables that look like they're going to last for a week or so. And I think that as we go through all of these different pieces, that understanding how we need to make sure that people have access to these is the basic first pathway. Now, people can choose to not utilize that pathway, and that's fine. We're still going to treat them. We're still going to put them in, walk through with therapy. We're still going to support them. We're still going to see them. We're still going to do those things. So you don't have to do that, but it should be offered ubiquitously, because methadone and buprenorphine are the only meds that have been shown to decrease mortality. Now, naltrexone has not been shown to decrease mortality. Bup and methadone have. There are no behavioral therapies that have been shown to decrease mortality in opioid use disorder. All they do is very important. It's all they do. What they do is very specifically help to maintain people in treatment and increase their function, which is important. But the mortality part really has to do with the medication on this piece. So that's an important piece. When we look at other aspects, that's where we have to start getting into what is the treatment system that we need. And as we start to think about the treatment system that we need to support this, we've broken this out into what I kind of call the 4 C's. There's probably a 5th, and we can talk about that one if you want. But and these are capacity, competency, consistency, and compensation. So these are the 4 pieces of building out a system of care. And it's important that we recognize that it needs to be right size. Like we don't need too much of something. Now we have a far cry from too much of anything at this point. But at the same time, as we start to get funding in this system and we build this system out, eventually we need to know how much is enough for a community. And then competency. What do you need to know to do this job? And then when we start to look at consistency, that's really quality. Like, how are we making sure that people are doing stuff well? We're making sure that, that they're delivering things at the right dose, that they're delivering evidence-based therapy and psychoeducation and those pieces, that, we're using good high quality practices for peer support and navigation through the system. And all of those things are there. And then compensation is, ultimately, we just need to pay for the system no differently than we do other healthcare in a sense, maybe not the same way, like RVU driven. I think we figured out a better way in addiction by taking the true biopsychosocial person into account as we start to do it. So let's walk through that a little more. So when we talk about the current state, the answers for all of those is no, we don't have those. Would anybody say that we have, there's always a place that you can get somebody when you need it? Yeah, no, I mean, clearly not. And the addiction treatment is not always adequately taught. Right now, medical schools still barely on board it. Social work schools barely talk about it. Psychology master's degrees, they'll lean in on it, but it's never been a focus, despite the density of this disease in our society. And in fact, if you work in the carceral environment, inside of a jail or a prison, it is the highest density disease in that population, addiction. You're not going to find any other disease that it is in a higher percentage of that population. And yet when I talk to people that work in prisons and jails, they're like, yeah, maybe we'll talk about that. We'll think about that. So when we talk about, do you have access to an addiction treatment provider? There's about 3,500 actively practicing addiction med docs and addiction psychiatrists in the country. There are 38,000 cardiologists. So this, and arguably there's much more need for addiction treatment than there is for cardiology treatment, because we have ubiquitous requirement for this all through adolescence, early adult, late adult, rather than mostly late adult for cardiology. So we've added basically two new generations onto the treatment modality for this. And the quality is, I got to say, I've looked at hundreds of places and it's mostly just terrible. And it's not terrible because people want to do bad work. It's terrible because we just haven't supported the development of the system in the right way. And then, I would say that a lot of the OUD care in the US is harmful rather than helpful. And what I mean by that is if you're a methadone clinic, then everybody who shows up there magically needs methadone. If you're a buprenorphine provider, everyone who shows up magically needs buprenorphine. If you happen to use naltrexone or the long-acting injectable form of it, then magically everybody needs that. That's not how we do medicine. It's like being a cardiologist and saying, I only use calcium channel blockers. That's it. I don't write any of these other blood pressure meds. If you need a calcium channel blocker, I'm your guy. You need a beta blocker, that's the guy down the street. And it's like having a different system of payment for each of those as well. And so it's a pretty messed up system right now. So if we dig into what is truly the right size system, we have to make sure that we understand the right size doesn't mean of one thing. So the ACM criteria has been around since the mid 80s and is really the national system of how we decide what level of care and intensity of care somebody needs with addiction. It's a biopsychosocial assessment, and there are multiple levels of care, which include opioid replacement at every level. It includes making sure that we have a team approach, because like I said earlier, this is not a singular treatment person disease. If you're a social worker, then you're a part of that. But if you open up and you hang your shingle and you're not connected with other people, then you're an incomplete treatment package. Just like as a doctor, if I said I treat addiction and I'm the only person they see, I'm an incomplete treatment package. And so as we look at, harm reduction and basically Maslow's hierarchy, we look at the system that we have here. And now I will say, as the editor-in-chief for the criteria, those that are familiar with it, we are coming out with the 4th edition next year, and we will be modifying some of these levels. We're going to be adding a level 1.5, which is a comprehensive outpatient treatment, which is a little bit like an FQHC model, and that, as well as we're going to be changing the way that we talk about residential treatment. We'll probably be increasing the intensity and type of treatment that 3.1s are required to have. We're probably going to add a recovery residency as a level of care, and if not 2 levels for that. And we're going to really define what recovery services should look like. What is the model for recovery services once a person has been in quote treatment for an extended period of time? What do we do to support them long term? And if we look at here, we've talked about all of these medications, and these should all be available at every place that they get to. Now, people shouldn't be able to dose, methadone at a primary care office. I think we would have some unintended consequences down that pathway, and most of us agree. But if you are an opioid treatment program, you should be able to give them not only methadone, but buprenorphine, as well as naltrexone. And oh, by the way, you should treat their tobacco use disorder. And oh, by the way, you should check for all their infectious disease issues. And oh, by the way, you should do a co-occurring exam. I mean, there are a lot of things that need to occur in these comprehensive treatment environments that don't, but will eventually, because we're pushing for that. And you can't just flip a switch and have people automatically do better work. Culture change is required, payment is required, and teaching and technical assistance is required. So these are big jobs, but I think over the next 10 years, we're going to really be able to get there. Competency. I'm going through this stuff pretty quickly because I see a lot of chats popping up. I haven't looked at those, but I'm assuming we have some questions, and I want to be able to answer those to a very deep degree so that we have plenty of time for that. Competency. Do we know the right things? So if I say, well, I'm going to train somebody to treat addiction, that really doesn't mean anything. Who am I training? Where are they going to work? Are they going to work at, so let's say I just take the example of a physician. Does a physician who works in the outpatient space need to know the same stuff as the person who treats withdrawal in an ICU? Not really. It's a different set of skills. What about somebody who works in a residential treatment provider as compared to an outpatient treatment, or in a hospital setting, or an IOP, an intensive outpatient treatment? It's not the same. So there's the same basic set of knowledge, but there are really specific skills that need to be onboarded depending on which level of care you work at primarily, and recognizing where that person is in their recovery in that level of care. So we have to walk through all of these basic pieces. What is the education, the training, the evaluation, for that we need to impart. It's not just given 100 hours of didactics, right? We've all been PowerPointed to death and Zoomed to death over the last couple of years. And I think that while we've increased some knowledge, we really need to help people understand how to apply this stuff in the actual place in which they work. And so it's not just a matter of educating someone, it's educating and then training in place, and then having oversight and evaluation and feedback, much like we have in medical care in places that do it well. The Institute of Medicine talked about core competencies. And if we look at every specialty, whether it's peers, social workers, whether it's psychologists, case managers, all of those national societies all have competencies that are defined. And so we need to basically teach to those competencies, and then we tweak those competencies based on the location of care. And so if you're a peer and you're in an emergency department, the skill set and knowledge base and kind of interaction style that you need to have there is really different than a peer in an outpatient setting where somebody's already been engaged in treatment and is much more stable. And so where you work means as much as what scope of practice you have. And then that interdisciplinary piece is really important. I've worked in this space for a long time, and I have to say I was not trained as a physician to work well with others. We were trained really poorly for that, to be honest, and most of us are condescending and difficult to get along with. And I will find that in addiction, that seems to not be the case, because we recognize it's a team sport and people are willing to know that I maybe need some input from my peer about what's going on. Not maybe. In the mornings before we'd see our patients, we would hear from our peers, our case managers, and quite honestly, I would modify my medical practice based on that every day. Do you do an early refill or not? Do we need to increase the dose of a medication or not? Should I start doing other evaluations for infectious disease or other co-occurring stuff or not? Those are all pieces of information that I can't get. If you're a peer, you're going to get more and more specific information than I'll ever be able to get. Because the minute that they walk in the room, there's a power dynamic that just shifts. And that power dynamic is helpful and detrimental at the same time. And just recognizing that it's there, there's so much that I can do to try to decrease that. But if we talk about inherent power structures, especially in these very vulnerable populations, I'm a white male doctor, which means that I hold a significant level of privilege and power in that setting, that if I don't recognize that and fully scale that back, that I'm not going to have a good interaction with a lot of people. And so I have to, physically call out very early in conversations the privilege that I hold in that space, the power that I hold. I physically get smaller in the room. I sit in the corner on the lowest chair in the room so that I can give someone else a feeling of equality in that setting, but it still isn't perfect. And it just doesn't ever work fully. You can do all of those things and you still need help with that, because they're still going to feel more comfortable many times with somebody else. So just recognize where you live within that power dynamic. And that is a competency that has to be taught. I mean, there are some people who are just, empathy Sherpas, right? These are people who just out of the gates, they can do all of these things. I had one of those in my clinic, Dennis Potter, and he started a clinic with me many years ago. And he was one of those that taught me most of this stuff that I espouse now. But and he was an LCSW, many years of experience, and really recognizing that. But if you don't have that interdisciplinary practice and teaming and training in order to be able to do that, it's hard to do. You really have to practice it. Consistency. I want to be able to know that someone who's been doing this for 2 months will give me close to the exact same result as someone who's been doing it for 20 years. The only way for that to happen are systems. You have to have consistent systems of care with some basic checkboxes that seem really boring and seem really frustrating, but every piece of research shows that the more that you systematize something, the more likely you are to make sure that it happens every time you see somebody. Now, that systemization, people will say, well, if you build that system too tight, then you lose the individual interaction. And I would say, I agree, totally agree. But there are basics that everybody should be doing, right? If somebody comes into a hospital and they're about to have surgery, we've recognized that if you don't have these systems in place, you might cut the wrong leg off. And we don't want to do that. So there are basic things that we do for every single patient, no matter what surgery they're happening, that these boxes get checked. And it was the same for us in our outpatient. We had an intake form and we had follow-up forms, and 85% of what we were going to do that day was based in those checkboxes. The other 15% was that individual interaction. And so be thinking about what is the 85% that's most important to happen over and over and over again, so that as we build these systems, it's predictable and consistent. And then compensation is one of those that people are always like, "Yep, I'll take a raise." Yeah, that's an easy one. But the thing is what we don't do in this is pay for the correct levels of care. Like, what percentage of people with an opioid use disorder require level 1 versus residential treatment versus IOP? And why is it that in some states, level 3.5, which is high intensity clinician driven, residential treatment, is reimbursed less per day than IOP? Like how does that happen? And so trying to figure out how we build those systems so that they're predictable and you can build these models of care. Because once we build it and it's predictable, then we're going to have hospital systems that want to be a part of this. Then we're going to have some structures that create good, oversight and quality and redundancy and, vacation packages, like things that people really do need in this specialty. Because I will tell you, if you see patients with severe trauma, well, you guys do crisis intervention, right? So you go to a place and you see a whole bunch of people with crisis, and you've done this after a mass casualty event, or you've done this after that, and I've done that in a couple of places. When you come home, the empathy train has left the station, man. There's nothing left in that tank for a while. And depending on the density of empathy you had to give directly relates to the amount of time you need to regenerate that empathy. You don't just wake up the next day and you're like, I'm golden. It's all for everybody else. That's the day the dopamine's at 40, right? That's the day we're calling in and not doing it. So having good reimbursement actually allows for you to build that redundancy in. It allows for you to have the capability to say, well, we only need really 2 therapists to see patients full time, but if we got a third, then we can rotate. So if we have 2 people seeing patients full time, but everybody would rotate out to do quality oversight and record review. Then we fix quality. We help to fix burnout because you're not always patient facing. There are ways to do this. And I will tell you, the people that are most emotionally connected to the work are the ones that burn out the fastest. The literature's pretty solid on this. So the better you are at your job, the likelier you are to have to quit in a few years because it's burned you out. Or the more likely it is that the thing that gave you the most joy turns into the thing that gives you the most frustration, which is even worse. And so I think keeping all of these things in mind is why compensation becomes so important, because compensation is not just the dollar value, it's how we build the systems. Do you build the systems to give emotional compensation back? Do you build the systems to give kind of respite, to the people who deliver this high intensity care? And that's a really important concept. Parity, blah, blah, blah. We can insert a slide here, but we'll go to here. So the conclusions to all of this, I think, is that I hope that you glean from this dense neuroscience, but still only a fraction of what we know neuroscience, that we really know what addiction is. We recognize that it's a derangement of the reward system that has modified the behaviors, that we deliver to the people around us, to the places where we live, and to ourselves, to the point of high risk. And whether that be drinking too much, whether that be taking opioids, whether that be using methamphetamine or gambling or video games or all of the above, what has happened is that the brain, the nucleus accumbens, the ventral tegmental area, the paracortical gray, orbital frontal cortex, the lateral habenula, the medial prefrontal cortex, all of these areas have been usurped or hijacked by whatever that activity is. And the body finds those things more valuable than the normal friendship we would have, than seeing your kid score a soccer goal, than having a great relationship, than feeling good because you did good at work. All of that just gets pushed aside when addiction is active. And so the goal, as we get to someone, what is the treatment goal? Well, obviously we want to make sure that people don't die from this disease, because I cannot therapize a dead person. They have to be alive in order for us to do this. If they've died from it, we've missed the boat. And so we've missed the boat hundreds of thousands of times over the last 2 decades. And so I think that it's really important for us to recognize that if not us, who? And if not now, when? To steal a phraseology from some historic figure whom I can't recall right now, but with it, I think that it's important for us to dig in and treat it, because we know how to do it. And again, opioid use disorder is easy, man, easy peasy. It is really the easiest one that we can treat, and that recognize that it takes a team and it takes a system. So you make sure that if you don't work in that portion of the system, that you know who does, so we can connect them, that you own the part that you own, and you open up to the fact that other people may have some really good ideas, no matter which side of this you come from, and work together to do the best thing for patients. 85% of this should be consistent, patient to patient to patient, person to person to person, should happen every time. 15% is where we can start to get really imaginative, is where we can start to be like, well, maybe this is a better treatment plan pathway for this person, and maybe that. And then I think, remember autonomy. I mean, it's ethically appropriate to allow for people to have the risk and benefit given to them and to make a decision that maybe we don't agree with. And that's okay. It's all right. Don't take that personally. This is just something that it's a difficult disease. People have their own life baggage that comes with it. And with that, we just need to sit with them in discomfort sometimes. Sometimes that's the best we can do. And I think that if you can do that, you're way ahead of the vast majority of people in this treatment space, because we so much want to fix people and fix people and fix people. But sometimes just being there is the best we can do. And that's okay. And if you recognize that, you'll have a longevity in this space a lot more than a lot of other people who get mad. Why won't they do what I say? Why can't they? I'm like, man, you're going to be done pretty fast. You need to just realize, it's like, why is my 9-year-old not doing exactly what I said? I will tell you why. So with that, I think we've handled the pieces that I really wanted to talk about, and I would love to get into any questions that you guys have. And again, I'm happy to answer. Even if I didn't talk about it, bring it on. I'm happy to take it. So if Susan, if you want to help moderate that, I'm happy to dig in.
Absolutely. Thank you so much, Dr. Waller. Excellent presentation. We do have a few questions. And if you want to direct message me a question, I will try to get it in here. We have about 30 minutes or so to go. So our first question comes from Stephanie. It says, if you are familiar with Pleasure Unwoven, would you recommend it to explain the medical model of addiction? And she's wondering if it's still accurate or if it's outdated.
I think it's outdated now, because we've learned a lot more about the other pieces, because addiction is not just about pleasure seeking. So the initial aspects of this piece and the parts of the brain that were talked about in that still have a place for sure. But it maligns some of the other aspects that are actually not pleasure at all, that have to do with habituation, that have to do with how we identify value, that have to, talk about how we, build what we call kind of click run behavior, which is reactive behavior that doesn't have cognition associated with it, that's just reflective. And so I think that it's a good start, but it's incomplete is probably the way to think about it. And so to see it as a totality of approach, unfortunately, would not do it. It's close. I think they could update that, but then the book starts to get really big and a whole lot less fun when you get to that.
Perfect. Melody asks, or she states, is it possible that while some people who have experienced trauma become wired to have hallucinations, paranoia, depression, anxiety, etc., others become wired to put their self-medication instincts in hyperdrive? Has anyone studied to see that rewiring also occurs in people who develop psychosis instead of substance use disorders? What are your thoughts?
Yeah. I've given that lecture a few times. So the neuroscience of trauma is really interesting. And it involves a number of portions of the brain. We have the neurochemical aspects of it that happen on a regular basis that have to do with the chronic expression of our own kind of epinephrine, norepinephrine, glutamate. So our very excitatory systems, as well as what happens from our mineralocorticoid system, like cortisol and things like this, that change that fight or flight all the time. The difference between tipping into psychosis and tipping into reflexive kind of trauma PTSD-based behaviors, we're thinking is more likely a genetic predisposition. And it depends on the age at which that trauma happened. Because there is there's a time in our lives where we do what we call arborization. Arborization is this terminology that very specifically refers to the trimming of the trees, so to speak. But when you look at when you're born with a whole lot of neurons that interact with everything. This is why you're like squirrel, and you're like, you can't focus on anything because everything is interconnected. And that as we work through life and we find pattern behavior, the brain starts to trim some of these so that there's not so much jumbled thought, so that we have more cohesive emotional responses and more consistent thought processes and the ability to focus. There seem to be some issues with this arborization. And part of schizophrenia, schizoaffective disorder, or even the depressive disorders that have psychosis that are associated with it seem to be because we have so many interconnections that inside voice that we may be thinking about this or your imagination. It's difficult when everything is talking to each other to determine what's imagination and inside voice versus what's happening on the outside. So it's just this thing of not really being able to tell the difference between reality and what we're just generating internally, almost like a dream. And when that happens, it becomes confusing, and people will have, psychosis from an excitatory sense because they're pushing out those that portion of the hormone. Some will have hallucinations. Some will have, a lot of these different aspects that I think many times gets called schizoaffective disorder when it's just kind of all disjointed and all over the place, and that'll meet that criteria. It won't be a hard schizophrenia for the positive symptoms on the negative side. So we are finding that almost all personality disorders are an outcome of trauma when we start to identify it, which is why medications don't really work, because it's a wiring problem. It's not a chemical problem. And you have to rewire it, which is why DBT is really helpful, because what we're doing with DBT is a consistent rewiring to a new default behavior. And so that takes a period of time, and that consistency is what helps to cause rewiring. So really important subject. It's a really fascinating topic, and one that we do know a lot about. Most of it is still kind of in the basic science realm. We haven't gotten to the clinical science side, but if you're bored and you want to read Frontiers in Neuroscience or Cell or things like that, then it's pretty interesting.
Wonderful. We have more questions, but I'm going to interject in here. With regard to trauma and the development of certain mental health disorders, personality disorders, is it also being looked into the role of personality?
Well, personality is just wiring. It's wiring. So the way to think about it is, personality is the equalizer, right? It's this 1980s equalizer that has all these little slides on there, and you're going to get your treble and your mid-range and your bass. So over time, we tweak a little bit of wiring, and that changes a little bit of this over here. We tweak one system, or we do that, and that changes personality. And so personality is the fine tuning of our hardwired system. And so when we have something like, people will bring up a question about things like marijuana. And so the endocannabinoid system, the part of the brain that's responsible, that produces endocannabinoids, our own cannabinoids, is meant to be a fine tuning system for a whole lot of different places in the brain. But when you take outside THC, especially at the high levels, we've taken something that's supposed to be just one of those little knobs on that equalizer, and we've turned it into a volume knob. And so we've taken away the clear majority of our fine tuning systems, and not just for personality, but for how we look at food, how we heal, how we grow bone. I mean, there's our immune system. There's a lot of stuff that it messes with, but and it's no different when we have someone with a birth genetic predisposition, right? That's their birth hardwiring. From that, the environment in which they're in tweaks the equalizer. And there are certain upper limits and certain lower limits, and we're identifying that, those can go a long way. Like if you take that whole thing and you crank it up, you realize that pretty well distorts sound. And if you push it all the way down, so you can take someone with pretty normal wiring and you can really push it to the point where it feels very abnormal in what it is. But it makes it even worse if you have somebody with wiring that is maladaptive to begin with, so genetic predisposition for schizophrenia, schizoaffective disorder, and then we also push all of those equalizers out of the way. But that also helps us because it tells us that if we have somebody with hard wiring that's maladaptive, we can modify that through inputs to get it back into this range of normalcy. And so, if we identify it, but the trauma is the biggest factor that we're identifying, and it sets it off, because by the time we recognize it, we're doing it as a history of trauma, not as an ongoing trauma. So the minute we start to see trauma as the disease we're actively treating, meaning in pediatrics and early adolescence, that's when we're going to get on top of this, because right now we're just trying to undo the trauma that we missed.
Mm-hmm. Excellent points. Thank you. We have another question. When the brain starts to kill the nerves that produce the dopamine, is that all reversible if someone is successful in recovery? And then there was a similar question from Laurel. Are those changes permanent? Once you have dealt with a long addiction to meth or heroin, will you never have enough dopamine again?
So great questions. And we have a pretty good answer thus far. So we're not sure the exact percentage, but there is a percentage of people who, after kind of capture into treatment and consistency within that treatment, will be able to, after a period of time, it seems to be around 3 to 5 years, be able to start to go back to produce their normal dopamine. However, there is a subset of the population, we don't know what percentage, 10%, 20%, 50%, that have injured that part of the brain. And no matter what we do, we will see a decrease in the production of dopamine permanently. And what that equals in some people is what we call anhedonic depression. So this flat affected depression. Mm-hmm. It's not the cry in the corner serotonin depression. It is the I don't care about anything depression. I can't motivate to get out of bed. I don't want to do anything. Hey, here's $100. Okay. Hey, you're going to jail. Okay. Hey, I'm repoing your car. Okay. I mean, it's just flat affected depression where you just can't care about anything. And so with that, what we have to do, if it's specifically called, well, interestingly, so there's some studies that are now in phase 3 trials that I've been able to see the early data from that look really interesting, and that they're using very small doses of buprenorphine, like 1 milligram doses. Normal doses are like 12 to 16 milligrams, but they're using like 1 milligram doses of buprenorphine to bump dopamine in anhedonic depression. And they're finding some very positive outcomes from that. It's still early. We still need to see more data, and they need larger scales for sure. But we've also seen medications like bupropion, which, when we give to someone, bumps central dopamine. And when that happens, we can see a little bit of that. And that's why it's helpful in that subset. So there is a subset of the population that chemically will bounce back. Typically the population that started later in life. And this is why we would find that all of the good data. So here's a stat, and I just want to throw it out there because I saw some in the chat before I started talking about abstinence-based pathways, 12 steps and recovery and that. So if I said 95% of people with a substance use disorder can be stable at 1 year purely by using 12-step recovery. Is that true? And then if I said only 8 to 12% of people who use 12-step recovery and abstinence-based approaches will be able to be stable, meaning 88% will fail. Both are true. And it depends on which population you're applying it to. So if you look at the vast majority of people who the literature for 12-step was written about, it was doctors, pilots, and lawyers. It was professionals, which means that they did not have such a dense utilization of substances in their adolescent stage or early adult stage that it actually impacted their schooling, because they were able to become a doctor, pilot, or a lawyer, and they were able to move through that. And so they didn't have that density of use early. However, what we're identifying is the population that seems to do poorly with abstinence-based 12-step recovery models are those that started utilizing their substance earlier. And so adolescent utilization, high intensity early adult utilization tends to not be able to recover in an abstinence pathway. tends to require medication, tends to require a deeper oversight with co-occurring illness and treatment for that. So when people come at me angry and they're like, well, 12-step worked for me, I'm like, that's awesome. I mean, that's great. I don't have anything against, that modality. But the data at the population level, which is what we have to build a system for. We don't build a system for an individual, we build a system for a population. And when we do that, we find that about 88%, if we just abstinence-based 12-step recovery, 88% don't. And that can be a death sentence for this population because the high mortality rate with these drugs. If we're talking about professionals who got busted because they showed up to their flight late and intoxicated, that pilot, if they follow the 12-step abstinence-based recoveries that are built into professional rehabilitation programs, at 5 years, 90% of them are fine, meaning stable and in remission without ever taking a medication. But we can't take that person and apply that to this other subset of the, of what that, what that looks like. So it's really important to recognize the pieces. Also, doctors, pilots, and lawyers respond to the persuasion of authority more so than the persuasion of social norm. So social norm, so authority, because they're an authority, I can say as a doctor, this is what this says and this is what it is, and they'll respond to that more often than another subset of the population, which is anybody started early and has really had to, had significant trauma and moved through these other pieces. They won't respond to me at all because what they're going to want is the social proof mechanism of this. They need somebody else to tell them that it's okay. It can't be me. And this is why without peers, the system is incomplete. And until we really finally added peers into the system, a lot of people died. A lot of people got lost to follow up. A lot of people, quote, weren't ready for change. And that's the only way we could put ourselves to sleep at night was to be like, well, they just didn't want help. What they didn't want was my help. What they needed was making sure that somebody else had their back and that they felt comfortable that this worked for somebody else, that this was the right pathway to be. And so as we talk about the permanence of this, there's going to be a subset of the population that will need to be on these meds forever. They have broken the happy part of their brain. It's like having a stroke. You're not going to grow those neurons back. You're not going to produce dopamine. I will say a worrisome tale is that all of the studies that have looked at weaning patients off over time, meaning they were on it for 2 or 3 years. There have been some that have done it a year, some at 2 years, some at 3 years, some at 5 years. All of those studies have shown very high relapse rates. And unfortunately, with relapse goes risk of death. So are there any other medications that we would voluntarily wean a patient off of that we knew increased their risk of death? No. And when people are like, well, my patients don't want to stay on meds. And I'm like, well, nobody wants to be on any medication. I don't care if they're hypertensive or diabetic or hypothyroid or, they don't want to, nobody wants to be on meds. It sucks to have to wake up in the morning and take a medication every day in order to kind of survive, right? Nobody wants that. So what I think it's important is for us as professionals who help to support these patients in their recovery is to help them realize that the benefit of taking these medicine far outweighs, the risk if they don't take it, and it's worth it. And you help them to look backwards at, look how far you've come. Look at all of the things you've accomplished. Would you want to risk that? And if they get to the point where they're like, yes, then fine, let's support them. Let's walk them through this. Many times what you'll find is you get them down to a small amount of medication and they're like, never mind. Can we go back up? I didn't like those thoughts that were coming into my head. I started really doing it. But a piece that we miss a lot on this population is that when we start them on medication, they have a rapid re-regulation of the brain. And if we don't surround them with a lot of good help and a lot of good support early, we lose them as well, because all of a sudden they have a clarity of mind of where they are in their life. And sometimes it's not good. Sometimes it's now I had a job and I had a family, and now I have no job. I have 2 felonies and my family doesn't want to see me. That's some rough stuff to deal with. And if they were going through cycles of intoxication and withdrawal, they weren't thinking about that. So the minute that we capture them in treatment and we start with these, treatments, opioid use disorder is one in particular that we can get some rapid, neurological stabilization. But the problem is that adds clarity of thought to all of that, really scary stuff.
Wonderful feedback. Thank you. We've got a few more questions we're going to try to get in here in the last 17 minutes or so. A quick one would be, Vincent wants to know, could you share the links or ways to access these studies that you've referenced for further research and understanding on our part?
Yeah, so if you go, I have the whole list of all of those things on the YouTube video that's connected with what I did, which basically is a version of what I just did. So if you just look up Addiction Neuroscience 101 and Waller, underneath that video, I've attached a Word document that has all the references and an explanation of how I got to kind of those general numbers. Yeah, so it's a lot. It's been a lot of years of kind of beating it up and recognizing that if you look at all the neuroscience studies, they're not easy to understand. I mean, I'm a neuromolecular biologist. I mean, I went to grad school for neuromolecular biology and I know this stuff pretty well. And when I go to try to read these things, somebody will say, well, this is the micromolar synapse concentration of dopamine. And nobody knows what micromolar synaptic concentration is. So what I did is I took a whole lot of studies, corrected them all for a single value, nanograms per deciliter, and then kind of averaged them out to that 50. And then I utilized the studies that looked at the percentage bump in dopamine with other substances to come up with that 1,100, 900, 700, and that. So you won't find a study that says 700 nanograms per deciliter. Those are extrapolated numbers from that first number that I found at stable dosing regimens, taking most of it is in the shell of the nucleus accumbens, because there's a shell and a core in that, but we're average those and then utilize those to extrapolate. I explained all that in that one pager, but it's important for people to know that you're not going to go find a study that I'm quoting, because I just did the calculations myself over the last few years to make it easier to explain.
Got it. Perfect. And the links were put in the group chat for everybody to see. So you can follow up with that for the references. We have a question from Dr. Chuck. He says, in our crisis systems, we are building capacity to identify opioid use disorder and start treatment immediately in crisis settings.
Yep.
Now the fourth wave of opioid stimulant comorbidities is showing itself to us on an everyday basis. We have guests with opioid use disorder presenting with more and more stimulant use, and now guests with only stimulant use in the past at high risk due to mixtures of opioids in their use, often unknowingly. It's laced and cut with everything.
Sure.
Can you comment on any specific tips or ways we can help address and support those presenting in crisis to our sites?
Yeah, so stimulant use is our next frontier of pain, unfortunately. Methamphetamine is ubiquitously available, super cheap, and it is, as I stated in kind of the numbers, it is really addictive. It is, it might be, so if you have anhedonic depression, meaning you've beaten up all those neurons, you can still squeeze enough dopamine with methamphetamine to still go above 100. So even when everything else fails, that might be. So what we found is a natural and predictable progression from opioids to higher doses of opioids to higher potency opioids to amphetamine, because it is the only thing that will actually begin to push out, enough dopamine for them to kind of disconnect from all of this piece. And so the treatment for stimulant use disorder is a period of withdrawal management and recovery. Now, that doesn't have to be residential because there's no risk of mortality to it. You basically, when you turn that off, they'll sleep for 72 hours. You got to make sure they're hydrated and things like that from a medical standpoint. But after that, the only therapy that's been really shown to be helpful for this is contingency management. CBT gives you a little bit, but you got to keep them retained in treatment long enough for it. Contingency management is 36 to 40% effective. And I would recommend, there's a few companies that are out there doing contingency management on a digital platform. The one that I've seen that does it right, and they've done randomized controlled trials on it as well, which I like, is Dynamic Care. I don't have anything to do with it. I've just reviewed it and looked at their outcomes and things, and it's a really effective, platform that is being paid for now by some state Medicaid people, and it looks like the state of California is going to start paying for it. So it's going to be available out there. There's some federal stuff that we're going to have to fix in order to make this really easily accessible, but that's the one. So the biggest piece that I would say is when somebody comes in and they have opioids and methamphetamine, we have to parse out, do they have a methamphetamine use disorder or an opioid use disorder? And they like to use methamphetamine. So I would say that if they have an opioid use disorder as a hard diagnosis, then they're definitely a good candidate for buprenorphine or methadone or naltrexone. But there are no studies to show that these medications significantly reduce the utilization of stimulants. So we need to recognize that the longer we retain them in treatment, the higher the chances are that we can decrease the use of those other substances. But really the only treatment for that is going to be contingency management, which is kind of tough to set up. And that's why I like the digital platform, because we set up a contingency management in our clinic, but it was funded through, like when I would go give a talk, we would just kind of fund it so we could buy gas cards and stuff like that. But that was the only way we could do it because it's just so hard to get it paid for appropriately from an insurance standpoint. But yeah, this is tough. And this is why when I say we build these systems, we should stop trying to build an opioid use disorder system and build addiction treatment systems and utilize those 4 C's appropriately so that we can build the right capacity for addiction and not just for buprenorphine, right? It's not the end all be all to this.
Thank you. Tanya wants to know, she says, you mentioned that there's not enough support and that things are not being done the right way. So what is the right way?
All right, well, let's walk through that. If we do the right way, so the basic concepts of the right way is to make sure that we use a validated form of an assessment, not what my gut tells me or what I think is the best or what it is, that we use a validated form of an assessment. And that is a 6-dimensional assessment where we look at withdrawal and intoxication. We look at their biomedical problems. We look at their psychiatric problems. We look at their readiness to change. We look at their relapse risk, and we look at their recovery environment. So those are the 6 dimensions of the criteria. If we look at all of those in a validated, systematic way, which quite honestly, the only way to do that right now is in the short term, it's called co-triage, and then continuum at the bigger ways. That's the only one where we have algorithms actually built into the system that pull from the criteria that have been studied not only in the US, but other countries as well. And from that, it'll map to a level of care. Within that level of care, a person should be given the evidence-based treatments that have been shown that they need there. So let's say somebody needs to go to 3.5 for an opioid use disorder. That means that person, to your point, during that assessment, let's say that assessment's done in the crisis center, should be started on medication so they don't go into withdrawal. So that would be an initial MAT, buprenorphine, super easy to do. Even if they bounce to other medications, that's the one to start at, because you can bounce to methadone, no problem, if they're going to go to an opioid treatment program. And naltrexone, again, if they end up in crisis, probably not the best place to start with naltrexone. You can get there. We had transitioned some people there after a few years. But the other piece is that when they get there, they should actually have systematic delivery of validated psychoeducation, so relapse, relapse prevention, anger management, seeking safety, things like that. And then you can follow into the psychotherapeutic modalities, which would deliver trauma-informed CBT, dialectical behavioral therapy, psychoanalysis if they have co-occurring and it meets that. Psychoanalysis by itself has not been shown to be effective for addiction, but as an accompaniment with other pieces. So those are, but if they go to 2.1, so if they go to IOP, intensive outpatient treatment at 2.1, they should also be able to get medication, and it's usually lacking there. And it doesn't mean that the IOP needs to do it. It just needs to be connected to someone who does it, right? They can be in separate locations, but they need to be connected and approached. And but they also need to have a high intensity psychoeducation with a little bit of psychotherapy. Not a lot of therapy needs to happen at IOP. There needs to be some clinician oversight so that if you identify co-occurring issues or that they can pop to, partial hospitalization. So we could go through this all day, but the key point is that you need to do a validated assessment, and then you need to have all levels of care available for whatever that assessment says. Because people will say, well, I don't know why we're using a structured assessment. It keeps spitting out this level of care we don't have. And my answer is that if an EKG showed a certain heart rhythm that needed to be treated by an interventional cardiologist, but you're in a small town and you don't have an interventional cardiologist, what do we do with those people? I will tell you, as a practicing ER doctor, we put them in a helicopter and we send them to where they need to go. So we need to figure out that system. And sometimes those systems are going to exist in their entirety in a single location. Sometimes they're not. I think every single town of more than 10,000 people should have an IOP and an outpatient treatment provider. And then you can refer to residential. And then residential, once they're done there, they bounce back to IOP with a warm handoff. And there should be a consistent utilization of the medication across it. And if you're in super remote, you should have outpatient with digital access to IOP and digital access to psychiatry. There's just no reason not to have that at this point. So there are ways to create the equivalent of a level of care, even in the most remote locations. And I live in Ann Arbor, Michigan, and I've done some work up in the UP or Upper Peninsula, and that is remote. That is middle of nowhere. And we still have a cell signal. So you can get what you need. And I think Elon Musk is going to fix our internet problem at some point. So once that happens, we can even get a pretty solid high-speed internet connection out to them so they can have visual visits with people.
Perfect. Yes, telemedicine is so important for us to utilize. Valerie wants to know, what is the best advice you give your patients who are on MAT that seems to help them to be the most successful in their treatment and recovery?
Well, I always start with, I never give advice, first of all. I've never lived their life. I've never walked in their shoes. I can't begin to understand how they feel other people say. So what I do for them is I make sure that 100% of the time they get a high five for me, that they're getting a very positive, motivational, interviewing interaction with me. When I walk in the room, I'm all smiles. It's so good to see you. How are things going? Oh, it's terrible. I'm sorry to see that. I wouldn't know it by talking to you. This is great. I mean, the last things I've looked at, you've done all these positive things. Well, in my urine, it's not going to be the same. It's going to show that there was something. Oh, well, that's, you've done so well up to now. So what do you think was that trigger for that? So it is about keeping that positive momentum moving forward, not feeling like you have to give advice, just giving information and support. And that's my role as well. If the patient says, I have parents all the time, like, right, there are not a lot of addiction medicine people around. And so I'm sure that all of us there, everybody's got a kid with an issue or an uncle or with an issue and that. So we get these questions all the time, like, what do we do and how do we do it? And the answer is you got to just tell them you love them and do the best you can to get them into treatment and support them. And it's really the best that we can do sometimes. And so it goes back to the best quote advice is the advice I give myself. And that's to not give them advice. It is very specifically just to support them in the pathway that they choose and to make sure that they have all the information they need to choose the pathway that's best for them. But really, we're many times, especially early in treatment, the only people that will support them. We're the only person. And so we have to be unfailingly positive in that. And I will tell you that there were certain Fridays that I could not be unfailingly positive with my patients. And so I would bail. And when I say, so we told our patients, I go, there are some days that I'm not going to be the right person for you to see. And you may have an appointment with me. I might not come into that appointment, not because I don't want to see you, not because I don't care about you, but because I'm just not the right person for you to see that day. Somebody will see you. And you'll get your refill and you'll get all those things. And if you have questions, please leave them with them and we'll get it taken care of. And so I just know I care enough about you to know when I'm not the right person for you. And so when my empathy train has left the station, I would tap out to one of my therapists or one of my peers or the case manager, or to my, medical assistant, if they were otherwise, whoever they connected with in the clinic or the area that we were at. And just recognizing that sometimes you're not the best person for them, and letting them know that, telling them up front, go, look, sometimes I'm also human, which means I'm not a great person in the moment. And I really want to be better. And I try to be better, but let's just recognize our limitations. And I think that's the best advice you can give yourself. And if you do those things, you'll have some longevity in this, and you won't feel the pressure to save the world. Because undoubtedly you will lose patience. I have a subset of the patients that I've seen I can't talk about specifically because I just lose it. Like there's just we were too like connected and too much work. And they're just not people I can like talk about in public about. And so realizing that putting that much into this, if you want to do this for a while and help more and more people, you have to take care of yourself. And so I would say that just be honest with your patients in every capacity. But unfailingly positive is where we have to be in this. That's really the place that we got to be.
Perfect. We have about a minute and a half left. I want to squeeze this one in. We'll have to be quick, but Joy wants to know, what have you seen in regards to equity and inclusion with medication-assisted treatment?
The data shows that we suck at it just as bad as we do in every other aspect of medicine. Okay. The medical care in the United States is structurally racist and compellingly horrible in that sense. Not only from the female, but the side, but the female of color, and then if you add in the pregnant female of color, it's draconian and is embarrassing from every aspect. And so I've been working with the Biden administration and SAMHSA to actually put together a subset of the money that's going to come down from the next SOR to specifically go out to every law school in every state. To identify all of the structurally racist aspects within the system, and to come up with remedies for those. Because at this point, it's no different than it was 60 years ago. And people are like, well, they have treatment. I'm like, I did street medicine in Camden for 2 years. I will tell you, it is no different. And so at the end, we just need to recognize that it's broken, why it's broken and how it's broken, and just frickin' fix it. I'm really kind of sick of a lot of people coming up with excuses about this, because we know how to fix it. And we're about to have billions of dollars in the system, and we have to hold our leaders accountable to do the right things with this. And so just know that those of us that work in this space are on board with this and recognize that issue to its fullest extent. Again, I've never had to live that. I've lived a very privileged white dude life. And so but I hear every single one of my colleagues and my friends and what they've had to experience in my patients, and it is appalling. And we just need to explode those parts of the system.
Excellent. Thank you, Dr. Waller, for your wonderful presentation and all the wonderful information that you provided for us.